Uh, Hello, everybody. Welcome to today's Young India Intensivist Critical Care Sunday webinars. Sorry, yesterday we could not have it because there was a medical emergency with one of the participants. We had to reschedule it to today. So, our apologies for that. So, we are doing this webinar of case discussions after some time. There has been a gap. And as many of you know, those of you who follow us, that we have done around 30 case discussions covering all the important topics. So now, we'll be taking a break from case discussions for 6 months. Next month, we'll be doing one on organophosphate poisoning, which is one of the commonest poisonings in India and many developing countries. After that, there'll be no more case presentations this year. All those case presentations, 30 of them are up there on our channel. So all the students can see them for their exams and all the young intensivists can use them for their daily practice and learning. So coming to today, today we have a case presentation from our very prestigious All India Institute of Medical Sciences, Department of Anesthesia and Critical Care, one of the leading institutes and ICUs in our country. So the case has been made possible by Dr. Bikash Ranjan Ray. Sir is additional professor and known to many of you. He is at All India Institute of Medical Sciences, Department of Anesthesia and Critical Care. And we thank him for making this case presentation possible. So the case will be presented by Dr. Raghupati. So Dr. Raghupati is a DM Critical Care Trainee at All India Institute of Medical Sciences. And along with him, joining the panelists for discussion will be Dr. Ravi Kumar. Dr. Ravi Kumar is also a DM Critical Care Trainee at All India Institute of Medical Sciences. So, friends, I hope that you will find this useful. So, this is a patient with acute hypoxemic respiratory failure in the post-operative phase. And before we start this, I will just like to mention that next Monday, we have a very important topic, high flow nasal cannula. And the speaker is a very renowned faculty, Dr. Tommaso Mauri. He is the inventor for high flow nasal cannula. And he'll be presenting the webinar. So I encourage everybody to attend the session next week on Monday. So over to you, Dr. Raghupati, to start the session.
Good evening. Thank you for the opportunity, sir. Today we are going to present a case of post-operative hypoxemic respiratory failure. Coming to the case, she is a 16-year-old female patient, laborer by occupation from Delhi, informant from her father, presented to AIMS ED with chief complaints of fever for 3 days, history of shortness of breath for 2 days, and history of cough for 2 days. Apparently, the patient was normal 3 days back. Later, she developed fever, which is of moderate grade of 101.2 degree Fahrenheit of last 3 days, which was intermittent in nature, which is relieved with medications. Associated with cough for last 2 days, which is productive, not associated with hemoptysis. Then
carry on. So, Dr. Raghupati, one thing, for you and for all the students, when you give the history and sometimes the patient is there in front of you, sometimes the patient is not there in front of you. It's very important to give an idea of the height and weight of the patient, because that comes into the picture very often. What is the height and what is the patient? Is he obese? Is he underweight? For example, this patient is likely to be frail and underweight. She's post-operative, and I think she whatever it is, right? So and many patients are obese, and the things change if the patient is obese. Your drug dosing, your fluid requirements, and vice versa. The patient is underweight. There are other kind of problems. So some kind of a estimated body weight and estimated height should be included in the history and presentation. Huh?
Yes, sir.
Okay. Now moving on to your history. So about intermittent in nature. We all present as intermittent in nature, continuous in nature. But does this have any relevance, Dr. Raghupati, intermittent in nature?
Sir, actually, initially traditional teaching was like there was like intermittent, intermittent, continuous, step ladder, different fever has been described. But in current scenario, this is not relevant in ICU perspective, sir, because we generally...
That is very good. Excellent. So, all this, like you said, these different fever patterns are described from many decades ago when there were no proper tools to actually investigate, so they used to rely on the pattern of fever. typhoid, malaria, etc., etc. But this has become irrelevant now, even outside the ICU. Fever is there, high grade or low grade, that's all. Right? That is very important. And most important is, when the patient comes to the ICU, whether the fever was recorded. Because any illness, they'll say most of the time there is fever. So recording of fever is most important. Then moving on to chills and rigors. So what is the significance of chills and rigors?
Sir, chills and rigors is the release of inflammatory cytokines into the bloodstream, which leads to high-grade fever associated with the chills because the body is trying to reset the thermostat. So there will be rigors and chills to increase the body temperature.
So if you're getting chills and rigors, what kind of fever, what is the etiology likely?
Sir, usually it is associated with a bacterial infection, and yeah, sir. Most of the time, it is associated with bacterial.
It is an infectious source. Can be bacterial, can be viral.
Can be viral.
So that is the chills and rigors are important. It is generally associated with infectious etiology. So that is good. Now moving on to cough with whitish sputum. So if the sputum is whitish, what does it mean? Is it any significant whitish sputum, yellow sputum, green sputum?
Sir, pertaining to this patient, since associated with fever, could be viral infection. Most common possibility will be viral infection, or else like early bacterial infection also possible. But other chronic bronchitis or other things are there. But since this patient history-wise, most likely infective pathology.
Yeah, so again, Dr. Raghupati, this whitish sputum, does not have much of a significance. If the patient has whitish, it could again be infective and any kind of infection. What is important in whitish is that if initially the patient has yellow greenish sputum and then it starts changing to whitish and becomes thin, then it implies this clearance of infection in the lungs. That is the most important thing about whitish sputum. Otherwise, even with whitish sputum, patient can get infection. And the green color of the sputum actually comes from the enzyme myeloperoxidase, which is found in the WBCs. So there's a lot of WBC breakdown myeloperoxidase release that leads to the greenish color in the sputum. Okay, great. Move on.
It is also associated with shortness of breath for last 2 days, which is acute in onset, gradually progressing, not associated with orthopnea and paroxysmal nocturnal dyspnea, not associated with chest pain, palpitation, syncope, no other history of generalized body swelling or decreased urine output.
So Dr. Ravi Kumar, what is the one point he should have told us about shortness of breath? What is important when you talk about shortness of breath? You have to say something.
Sir, in this case, when the shortness of breath is post-operative, we have to know whether it is acute in onset, right? But whether it was sudden in onset, suddenly appeared, or whether like it was gradually onset is gradual or not is.
So that is in the ICU, so it may not apply to this. But supposing a patient comes from shortness of breath, dyspnea from outside admitted to the ICU, what is one point you'd like to tell which is not there in this? You have to grade. You have to classify the amount of dyspnea. Dyspnea classification is there. There is a cardiac classification, which is New York Heart Association, NYHA classification for cardiac dyspnea in cardiac patients. And there's a
MMRC.
Classification in pulmonary patients. Right. So NYHA classification is 1 to 4, 1 being the least and 4 being the highest, and MMRC is 0 to 4. So in this, it may not apply because the patient is at rest on the bed. But if the patient comes from outside, you should try and classify the amount of dyspnea. It's very important. It's a very important point. Okay. So moving on to orthopnea and PND. So why is this important, Dr. Raghupati? Orthopnea and PND?
Sir, to rule out cardiac cause, so mainly to differentiate between cardiac and respiratory causes, orthopnea and PND is mostly related to heart failure symptoms, sir. And chest pain, palpitation, syncope also mostly it's just to rule out a cardiac related shortness of breath.
So what is the physiology in orthopnea and PND?
Sir, orthopnea is like whenever the patient lies supine, there will be increased venous return to the increased venous return to the heart, and it ultimately leads to pulmonary edema and waking up of the patient. Patient can't lie supine. Sir. That is orthopnea. Whereas paroxysmal nocturnal dyspnea, when the patient falls asleep, when the systemic vascular resistance comes down, there will be shifting of intravascular fluids into the interstitial space, and that will leads to nocturnal dyspnea, usually which occurs middle of the sleep.
Okay.
So the patient will be breathless during this.
Okay. So this is true, whatever you have said, but orthopnea is also seen in respiratory patients because when they lie down, the diaphragm goes up, and if the respiratory reserve is less, even these patients get orthopneic, when they lie down. So it is not a very clear this thing, but just definitely it helps. So I agree with you. Okay, next slide.
Coming to the past history, patient was a known case of corrosive ingestion with toilet cleaner. She was admitted for the same during last year, 5th of July to 1st of August. She was admitted in AIIMS, and during that course, she underwent feeding jejunostomy. She had a this time she post that she underwent investigations to look for the extent of corrosive injury. Barium swallow showed a stricture in the esophagus. Endoscopy showed there was a diffuse corrosive injuries to the esophagus and stomach of grade 2A and 3A. And but there was no evidence of any bowel perforation in the CT.
Okay, next slide.
Personal history, patient takes mixed diet, bladder and bowel habits normal, sleep was normal, appetite is reduced, and no history of addiction or illicit drug intake. There was no other significant history pertaining to the current clinical scenario.
So one thing is, you said she's a laborer, right?
Yes,
So
yes,
what
sir.
kind of a laborer? Farm worker, home worker?
Home worker, sir. She used to do household works in the nearby homes.
Okay, household works. So this is also important, because she's working in the farms, etc. Then she's exposed to all kinds of dust. There can be dust, or if she's working in stone quarries and all, then she can be exposed to inorganic dust. So all this also leads to lung disease, which becomes important because she has dyspnea. So underlying lung disease also has to be thought of. So but it's important. Background history is very important. What if, whether the patient is on medications, and she's on a feeding gynostomy, so it becomes very important whether there are any nutritional deficiencies, right? She must be underfed, not getting proper vitamins. So any signs of vitamin deficiency becomes important. Bursitis, scoliosis, skin scaling, so many things are there, with vitamin deficiency. Okay, move on.
Currently, she was planned for elective surgery. That is like post-corrosive injury. She was underwent feeding gynostomy. Now she is planned for colonic pull-up plus pharyngoplasty, for which she was admitted during the March 7th to 18th. That time, he was hemodynamically stable on arrival. GCS was full. Initial examination, ENT examination was normal. She underwent elective pharyngoplasty with cologastrostomy with gastrojejunostomy and feeding jejunostomy on 19th of March. Then during the surgery, patient had hemodynamic instability, and since it's a prolonged surgery, she was not extubated and shifted to ICU. She got extubated on day 3 of ICU stay. She was on cefotaxime and metronidazole during that period.
So this hemodynamic instability is what, Dr. Raghupati?
Sir, during the surgery, patient had a blood loss of around 800 ml to 1 liter, sir. That time she had requirement of vasopressors. That was a very brief period. And otherwise, the patient vasopressor has tapered off once the patient has reached the ICU.
So she was not on vasopressors after coming to the ICU?
Sir, actually, after few hours, 3 to 4 hours, we tapered out.
Okay, so a lot of blood loss was there, huh? So she
Yes,
required vasopressors.
yes, sir.
Okay, so now she has moved. She's in surgical ICU. She's extubated. She's extubated.
Extubated on day 3, POD 3, mein she got extubated.
Okay. So Dr. Vikas sir, Ray sir, whenever you want to ask or intervene, please, sir. Please.
Yeah. Yes, sir. Yes, sir.
Okay, next. Yeah, carry on, Dr. Raghupati.
Yes, sir. So post extubation, she was doing well. GCS was 15, hemodynamically stable. But gradually, her oxygen requirement went up. Initially, she was started on face mask. The requirement of oxygen has increased from POD 4. The next day, she developed a high-grade fever of 101, associated with cough, with sputum.
Okay, so she has developed fever, hypoxia. So when she was extubated, she was not requiring oxygen.
Yes, sir.
Okay.
Yeah, Rakupati is probably stuck.
Raghupati has got disconnected.
Developed two episodes of Melina with FJ side fresh lead.
1 minute. Previous,
Rakupati, you are not audible. Can you go back to the previous slide, please? Yeah, continue.
there's a problem with this. Dr. Raghupati, hello, I think he might, Dr. Vikas, yeah, I think he might have an electricity cut down or something.
Okay, he was in hostel probably.
It have occurred at his place. Let us wait till he joins.
Okay, okay.
Hello. What happened? Light went off? Yeah, okay, okay. Yeah, yeah, I understand. Yeah, yeah. So friends, he's just coming. There was a power cut. He's just joining now. Just 2 minutes.
Sorry, sir.
No, that's okay. Huh? Power cuts happen. It's not your fault.
Uh, Post-operatively on day 5, patient developed fever, cough with sputum protection. Then during that time, central line was changed due to there was some thrombosis in subclavian vein, and anticoagulant was initiated. Simultaneously, the patient developed 2 episodes of melena, FJ site, fresh bleed, and there was a significant drop in hemoglobin from 9.5 to 7.3.
So, Dr. Raghupati, why was there leakage in the line, central line?
Sir, this is, sir, actually, it is due to malfunction of the central line, sir, not related to any other pathology.
What malfunction? What is malfunction? Why is the central line? So, Doctor, why is the leak in the central line? What are the causes of leak in the central line? It is a backflow, back leak. What is the cause? Ravi Kumar?
Sir, can be due to like if during dressing and all, if the sister pulls it out, if even a single port is out, that can be due to leak.
Port is out, but for that, a lot of it has to be out. What other thing? What is happening here? Right in front of you. There's obstruction to the flow, right? There's thrombosis in the line. There's thrombosis, right? So the thrombosis is no forward flow, will come back only. It will be backward leakage. Huh? Now, and it's very important you have given 0.6 mg PD. What is the weight of the patient?
52 kgs, sir.
She was 52, huh?
Yes, sir, 52 kilos.
So that is predicted body weight or actual body weight?
Sir, predicted body weight.
Predicted body weight is little different, you know, you have to give as per the actual body weight.
Yes, sir.
So she was on a feeding dystostomy, and what is her height?
Sir, 158 centimeters.
158. So she must be 45 kgs, I think, not more than that. So
Yes,
this
sir.
might have been a little higher for her. Anyway, so she developed thrombosis. Was she given post-operative prophylaxis?
Yes, sir. Prophylactic anticoagulant was there. Since there was a thrombosis, it was converted to BD. Initially, OD dose was started. POD2.
Was receiving post-operative prophylaxis, huh?
After 48 hours, it was started.
Okay. So then you can't do anything if she was getting post-operative prophylaxis and she develops SCV thrombosis. Okay, move on.
Then for that episode of bleeding, the anticoagulant was stopped and it was corrected with vitamin K plasma, and then PRBC was administered. She was taken for CT angio. There was an active contrast blush seen at the feeding jejunostomy site. But all the melena and other bleeding has stopped after the blood products administration, and the patient was conservatively managed for that episode. Medications at that time was cefatoxime, metronidazole, fluconazole, and it was escalated piptaz and ticoplanin during that suspected anastomotic cycle. Otherwise, patient was started on total parenteral nutrition from post-operative date.
So, Dr. Raghupati, when CT angio abdomen was done, was the CT pulmonary angio done?
No, sir. Only abdomen, since there was a bleeding, there was an emergency CT angio abdomen only done, sir, not CT PLS.
So, she is becoming hypoxic and everything, and she has a thrombosis. Why was it not considered pulmonary embolism?
Sir, since there was a...
She has gone down to the radiology suite and she has a pulmonary embolism. She has a thrombosis in the SCV. She could have embolized. She's become hypoxic. So I think it should have been done. It should have ruled out pulmonary embolism. Now, once she has got a CT angio abdomen done, it hardly takes anything to do a CT pulmonary angio. No, you agree?
Yes, sir.
There
was the secretion and fever spikes and all more. We thought of pneumonia.
No, you are getting
yeah, what you are telling, Dr. Bansal, is correct, absolutely correct. At this time, the patient was in the ward, in the surgical ward, and this is the post-op day 4. That day, the patient started respiratory distress, so that should have done that. But at that time, it was only they have concentrated on the bleeding part only.
You see, patient has fever, patient has hypoxia, patient has a proper thrombosis. You have to rule out pulmonary embolism. Especially she has gone down to the radiology department.
Yes.
Doesn't do, huh? So this should have been done, right? And I think you cannot rule out pulmonary embolism in this patient. She's become hypoxic. She has fever. She has SCV thrombosis. Okay, move on.
So during the post-operative period, there was nothing changed much different in the investigations.
Whatever important point is there in investigations, you can tell. That's all.
Yes, sir. Otherwise, there was no increase in the TLC. There was a gradual drop in the platelet. She had a gradual thrombocytopenia, and there was some amount of hemoglobin loss was there that during that episode. Otherwise, nothing significant.
So why do you think there is a drop in platelets?
So, could be sepsis-related thrombocytopenia or like heparin, even it is less common. It is like anticoagulant-induced, heparin-induced thrombocytopenia could be the differential. So most commonly sepsis-induced thrombocytopenia. This time she was in fever and could be pneumonia. So that might be one reason.
So has she received heparin?
Sorry, sir.
Has she received heparin?
Sir, low molecular weight heparin she received, sir. Here.
So you think she has developed HIT?
No, sir. First possibility will be sepsis-induced thrombocytopenia.
So where is the sepsis?
Because like that only within third day the patient started having thrombocytopenia. Usually it will take 5 to 7 days for the onset of heparin-induced thrombocytopenia. That too with low molecular weight, it is very very rare. Most possible will be sepsis-induced thrombocytopenia.
No, this thrombocytopenia has occurred on what post-operative day?
Sir, POD 4, sir.
So that is on the day she developed fever, hypoxia.
Yes, sir. Yes, sir.
I think it's a bit too early. She's just developed a little bit of infection or whatever she's having. So what else can cause thrombocytopenia in this?
And she was on same day she was started on antibiotics, ticoplanin, or else like drug-induced, or like enoxaparin. Then these are all the
same day. Do you think the drug-induced thrombocytopenia by ticoplanin will be on the day 1?
No, sir. So usually it take at least 5 to 7 days after starting ticoplanin, sir. It won't occur in the day 1.
So, Dr. Raghupati, there is HIT 1 and HIT 2. So, what is HIT 1?
Sir, HIT 1, usually it is more, HIT 2 is more likely, more severe and is immune related, which is caused by antigen antibody complex, immune complex related, like PD4 receptor along with the antithrombin that forms a complex and causes a paradoxical thrombosis all over the body, leads to conceptual thrombocytopenia. So which is more severe and which is more common, whereas HIT 1 is it's like a direct what is it? Direct destruction of the platelets. It's not immune related. HIT 1, which is mild and less common.
Ravi Kumar, what is HIT 1?
Sir, HIT 1 early phase during the first 4 days of starting heparin will happen with a small drop in platelet count, not very much drop. Like it won't go beyond like something like 50,000 or something, and there is no associated thrombosis. There is associated thrombosis with HIT 2 only.
So this can be one, right? This can be HIT 1 because of Clexane. This can be HIT 1 because of Clexane, can be because of related to the fever child she is developing. HIT 1 and HIT 2. HIT 2, you are right, Dr. Raghupati. HIT 1, you are right, Dr. Ravi Kumar. There is a transient drop initially, which recovers. That is HIT 1. And that occurs immediately. All right. So that is the thing. And other thing is, you should always rule out artifactual thrombocytopenia. Right. You have to confirm that this is thrombocytopenia. Sometimes it can be spurious low readings. Always rule out thrombocytopenia, proper thrombocytopenia once you get low counts. That's very important. Okay, move on.
So these are all the serial X-rays during the post-operative period. Gradually, the patient developed bilateral diffuse infiltrates, mostly on the right side, mid-zone and the lower zone.
So, Dr. Raghupati, what are you seeing in the POD5 X-ray? Is it infiltrates or what do you want to call this?
Sir, definitely there are increasing infiltrates predominantly in the lower and mid zone. So could be since it is more localized, could be infective, sir.
No. This Dr. Ravi Kumar described the X-ray findings on POD5.
Sir, this X-ray, it's a AP view X-ray with right-sided CP angle blunting showing some pleural effusion, and right-sided probably effusion-related collapse and some amount of infiltrates with GGOs are there. Left side also there is CP angle blunting. There is effusion here, and some pulmonary hilar dilatation can also be seen in this X-ray.
On which side?
Sir, left side more than right side, sir. Here.
Actually, you see, pulmonary dilatation very difficult to say. What is there is both bilateral CP angles are gone and right side is more involved. The right side gross haziness. Okay, the likely cause is bilateral effusions, right more than left. And on the you cannot see the right cardiac border. Right heart cardiac border cannot be seen. Right, and when that happens, that is called a Silhouette sign. That means there are infiltrates in the right middle zone. Right heart cardiac border cannot be seen. So there are infiltrates that could be atelectasis also, but that is not the picture, X-ray picture of atelectasis. Whenever the right heart cardiac border is gone, that means there are infiltrates of consolidation in the right middle zone, and bilateral effusions seem to be there. Underlying the effusion, there could be some collapse, some infiltrates we cannot say. For that, you need a CT. Yeah? That is what you can say in this. There is no clear evidence of any pulmonary embolism in this. There is no clear evidence of any pulmonary embolism. You cannot say anything. Okay, next.
So, summary, patient is a 16-year-old female who's a post-operative case of colonic pull-up with pharyngoplasty done for post-corrosive ingestion with esophageal stricture, currently presenting with cough, fever, and shortness of breath on post-operative day 6. The differential diagnosis were hospital-acquired pneumonia, acute respiratory distress syndrome, volume overload, DAH, and pulmonary embolism. Mediastinitis, aspiration pneumonitis are less likely. Most possible diagnosis will be hospital-acquired pneumonia with ARDS.
So, Dr. Raghupati, can you say ARDS just now? Do you have the criteria?
Sir, we have acute onset of hypoxemia. There is chest X-ray infiltrates, but we can say with the help of either SF ratio or PF ratio, sir. If saturation is less than 97 with acute onset of insult,
Rajat, you can discuss.
No,
Whether you
Dr.
can...
Kumar, maybe you can take over the discussion.
Right.
I think he's got disconnected. So he's back. Okay, Ravi Kumar, carry on. Doctor,
Sir, the global definition of ARDS was recently published, which says which defines the ARDS like this: the acuity of the onset, like 7 days.
we will discuss the use in this patient as of now. Can we say the patient has ARDS?
Right now, because we don't have SF ratio or PF ratio in this patient, and we have not ruled out the cardiac cause as such.
Very good. And also, you know what is there in the definition is hypoxia should not be explained by effusions. Right? Right now, what you are seeing, you are not sure whether that is effusion or infiltrates. It looks more like effusion to me. Okay, and there is a possibility of pulmonary embolism. So where are the infiltrates? There are no clear infiltrates, bilateral infiltrates. So right now you cannot say ARDS. Now coming to hospital-acquired pneumonia, that is possible, I agree, but there are some infiltrates. So what predisposes to hospital-acquired pneumonia in this patient? What are risk factors?
Sir, since this patient is like a post upper GI surgery, since we can consider it as an immunocompromised, since already she had a antibiotic exposure and all, that could be one of the risk factors for hospital-acquired pneumonia. Otherwise, there is no other risk factors for it, sir.
Ravi Kumar, what are the risk factors in her for hospital-acquired pneumonia?
A major abdominal surgery, if ineffective pain relief, if it is there, inability to breathe will be a risk factor. Patient will be immobilized after the major abdominal surgery. That can be a risk factor. Like ineffective chest physiotherapy post major abdominal surgery will be a risk factor in this patient. Yes, sir. These are the major risk factors.
Was she malnourished? You have seen the patient. Was she malnourished? Was she underweight?
Sir, sir, around 45 kgs.
You can see the patient in front of you. Was she
Yes.
underweight?
Okay.
Sir, moderately built, malnourished. There was no malnourishment, but she was like thin built and
No,
weight.
if she's on feeding dysnosmia, she has to be underweight. No, she has to be. She cannot be normal. Was she normal body weight?
No, sir. Actually, on the BMI is around 19.
Yeah, so
19.
she has to be like that. No, feeding dysnosmia, laborer. I don't think she can. She has to be normal. So if the patient is malnourished, that leads to immunodeficiencies, right? Body weight is less. Okay, that is one risk factor. Second is what about blood transfusions? Multiple blood transfusions is a risk factor for infection.
Yes,
It's
sir.
a risk factor. Blood transfusions.
Yes, sir.
How?
Sir, usually platelet transfusion is more associated with infection, but other viral infections are also possible. But hospital acquired pneumonia is very not fully correlated with blood product transfusion.
No, even if the blood is not transmitting directly, is blood transfusions a risk factor for overall infections?
Overall infection could be possible, sir, but
Transfusion-related immunomodulation will be there. So that is
You tell Dr. Ravi Kumar.
transfusion-related immunomodulation will be a risk factor that causes immunodeficiency in such patients, and overall, it is a risk factor for any hospital-acquired infections, sir.
Yes, so blood transfusions, they lead to immunomodulation. They are risk factor even if they don't they do cause directly. And any patient who undergoes prolonged surgery, especially upper abdominal surgery, is predisposed to post-operative pneumonia. Okay, especially prolonged surgery. This is a major surgery. There is intra-op hypotension. All these factors are risk factors for this thing. And very important, she has a pharyngeal surgery. Was she having dysphagia? Was she aspirating?
Actually, there was a suspicion of aspiration. So since that high pharyngoplasty was done, there was a difficulty in definitely, she was not allowed orally, but there could be a possibility of micro aspirations.
She was having some oropharyngeal dysfunction. Maybe she was aspirating. So many factors are there, right? She was at high risk for hospital-acquired pneumonia. You can actually call this ventilator-associated pneumonia in a way, right? So there's not much of a difference here. Immediately after extubation, she has developed pneumonia. So this is actually the ventilator-associated pneumonia almost, or whatever you want. These are the risk factors. And you cannot call it ARDS just now. The volume overload, that I don't think she was volume overloaded. The DH, why do you think she had DH?
Sir, since it is an acute onset, young female patient presenting with hypoxia and it is not a immediate possibility. Slow it down my diagnosis.
So what is
the
etiology you think of DH in this? What is the etiology you are thinking?
Sir, could be autoimmune diseases like pulmonary renal syndrome also possible in this age group. But this is not the prior main differentials. But there was some drop in hemoglobin also. So that's why DIH also kept in.
Yes, Dr. Ray, please carry on.
No, you can definitely say that there is a history of bleeding before the onset. So that may lead us to think that there may be bleed inside the lung also, but there is no other risk factors for the DH.
She was bleeding on Clexane, right?
Yes.
So can Clexane bleeding lead to bilateral this diffuse alveolar hemorrhage? Can cause, if your anticoagulants can cause significant pulmonary hemorrhage?
Very unlikely, sir. It won't have pulmonary hemorrhage.
Ravi Kumar, can it cause significant pulmonary hemorrhage, anticoagulant use?
Anticoagulant use is also described as one of the causes for DAH, sir.
Very good. So it can cause, there's no problem. Once you start bleeding on an anticoagulant, it can actually, you can bleed in the brain also to death. Nothing is stopping bleeding anywhere. Bleeding can occur anywhere, lungs, brain, and people have died. You must have seen also, I don't know whether you have the experience, people die of bleeding anywhere once bleeding starts. Bleeding is very dangerous. Lungs and brain also. So once you are bleeding, you will bleed anywhere. Whatever pulmonary embolism we have already discussed, why do you think she had, why do you think the possibility of mediastinitis was there?
Since she underwent open thoracostomy with pharyngoplasty, there could be local infection which may cause mediastinitis through bloodstream.
Okay. Okay, I agree. Then aspiration we have already discussed. Huh? So could there, so these are factors related to what happened in the ICU. Sometimes, what happens is you think it's related to the ICU, but something else is happening in the patient. Unrelated diagnosis. So anything you can think of unrelated to the, surgery or anything which could be happening in her? One you said autoimmune disease could have flared up. She might have a new onset of autoimmune. So this happens. It's good you have thought. Okay, unrelated things also happen. One has to think of all the possibilities. Anything else?
Any tropical fever which coexisting leads to ARDS?
Be there, she may have acquired malaria bite or something. She might be, that is one possibility. I agree. What else? She's a laborer. Remember, she's a laborer. What else can happen? Something in the lungs. So worm infestation migrating to the lungs. Very rare. All these things also happen. Worm migration to the lungs is a laborer. So one just trying to make you think laterally. All these things are also possible, which can flare up and are not related to what is obvious. One has to think of all the possibilities. But whatever you have put up is the right differential. But mediastinitis also has to be thought of because the pharynx and all have been opened up. Okay. Why do you think she had pleural effusion? Does she have pleural effusion? Let us go on. Let us see what she has. Carry on.
Now we have shifted the patient to our ICU on postoperative day 6. On arrival, examination, central nervous system, she was like GCS was E4, V5, M6, bilateral pupils normal. Cardiovascular system, nothing significant. Respiratory system, bilateral air entry is present. Crepitations were there, diffuse bilateral. There was a decreased air entry, more on the right side compared to the left. Respiratory rate of 35 to 40 per minute. Saturation of 94% with NRBM at 12 liters per minute. Abdomen, otherwise, she soft and non-tender. There was a 2 abdominal drains with collections per day around less than 100.
So the crepitations you have to localize. If you're giving the exam, you have to tell the crepitations where the crepitations are. Not only for the exams, they help to localize where the disease is. So you have to know where the crepitations are. That's very important. Infrascapular, left, right, base, that you have to tell. That's very important. That localizes the disease. Okay? Just crepitation is not good enough. And if the saturation is 94% on NRBM 12 liters, what is the FiO2? Can you calculate the FiO2?
Yes, sir.
How much is the formula for NRBM?
Sir, for every liter, 0.03 FiO2 has to be added after 0.21.
What is the FiO2 on this NRBM? Ravi Kumar, what is the FiO2?
Sir, around 58%.
So 12 into 0.3, okay? So it becomes every 1 liter 0.3. 12 into 0.3, 56 plus 21. That is the base, right? So it is 57, 60, around 60%. You have to multiply the liters into 0.3 and add that to the 21% base. Okay, that is how you calculate the FiO2 on NRBM. Okay, so now you have some involvement in the respiratory system that you have, and there is tachycardia. Okay, and neurologically she is normal. Okay, move on.
Coming to the focus lung showed bilateral lung sliding, bilateral subpleural sets predominantly on the right side compared to the left. Right side pleural effusion around 1.8 centimeter, very minimal left-sided pleural effusion. Otherwise, echo showed normal LV functions and normal RV functions. There is no pericardial effusion. There was less than 50% variation in IVC, and bilateral femoral veins and popliteal veins were compressible.
So what is the lung diagnosis, ultrasound lung diagnosis?
Sir, bilateral effusion more on the right side, and there was some amount of subpleural stenting, which is most likely could be pneumonia, consolidation, or ARDS, because it was on the bilateral side. Predominantly on the right side could be infective is the first common, followed by ARDS.
Okay, next slide.
She was started on high flow nasal cannula with 60 liters flow and 60% oxygen. But there was a worsening clinical status and the ROX index. The patient was intubated.
So 1 minute, just go back. What are the cause of the effusion, bilateral effusion?
Sir, first cause will be there could be a lot of fluid shift with upper GI surgery. It could be a transudative secondary to the upper GI surgery, or it may be exudative because of new onset pneumonia. Since the patient urine output and cardiac functions were fairly normal, unlikely due to it could be cardiac failure or renal failure related effusion. So it's more likely transudative reactive effusion secondary to the upper GI surgery.
Absolutely, I agree. And it could be if the infection also could be contributing. I agree. Okay. Why do you get in upper abdominal surgery? Why do you get effusion in upper abdominal surgery?
Sir, since lung is the first organ to just to take the inflammatory stress caused by the surgery, so it's basically a capillary endothelial leak which is occurring during the stress of the surgery.
Wrong. That's not the reason. The diaphragm is involved. There is irritation. Upper abdominal surgery, there is diaphragm injury. You handle the diaphragm, there is diaphragm irritation, so there is shift from the upper abdomen to the lungs, to the pleura. That is the reason. Any surgery where the diaphragm is handled, diaphragmatic irritation is there. There is a fluid movement from the peritoneal cavity to the pleural cavity. That is the reason. Not because of alveolar capillary injury in the lungs. That is not the reason. Okay. So you have put the patient on high flow. Okay, initial setting, this thing. So Ravi Kumar, how do you set the initial settings on high flow nasal cannula?
Sir, FiO2 is set initially when we are stabilizing the patient. We'll start off at 100%, then you can bring down to a target saturation of 88 to 92% in the ICU. The FiO2 is set like that. Then the flow is set according to the respiratory drive of the patient. If the patient's respiratory drive is high and the inspiratory flow requirement is very high, then we'll keep it at 60 liters. Then if when the respiratory rate goes beyond like 30, 35, we'll keep it at 60 liters. Then we'll bring it down as and when the respiratory rate and the respiratory drive stabilizes, sir.
How do you know the respiratory drive on the patient when the patient is on just oxygen mask?
Sir, we can see clinically with the respiratory rate, there'll be nasal flaring, there'll be tachypnea with due to the hypoxemia, sir.
What are the components of respiratory drive?
Sir, chest, intercostal muscle indrawing, like sternocleidomastoid, and the patient will have a nasal flaring, and the patient clinically looks very toxic and distressed.
That is signs of respiratory distress, respiratory hunger. But what are the physiological components of respiratory drive? There are only two components.
Hypoxemia will be.
No, that is not respiratory drive. What is respiratory drive component? There are two components. One is respiratory rate and tidal volume. Respiratory drive has two physiological components. One is respiratory rate, the other is tidal volume. Tidal volume you cannot say by seeing the patient. Nobody can say. Only RR you can say. So respiratory drive high, if the tidal volume is normal, then what is the respiratory drive? You don't know. Okay, you can just say the patient is in respiratory distress. And that is not the proper way to set the high flow nasal cannula, Dr. Ravi Kumar. I don't agree with that. Dr. Raghupati, how do you set the high flow nasal cannula? What is the way described?
Sir, major trials have shown in that they set at initially at 60 liters, then they will adjust according to the CO2 levels, PaCO2 levels. And then clinical parameters like patient heart rate, respiratory rate, and workup breathing. Basically, if the workup breathing is coming down, then we can bring down the flow rates. That's what it's described in the latest major trials. That's how it was conducted.
Do you start at a lower flow rate or a higher flow rate?
So since the patient was already tachypnic, I will start on higher flow rate.
No,
Then,
that's wrong. That is both of you not saying the right. See, initially you have to go from a lower to a higher, not higher to a lower. All right, you have to go from a lower to a higher. Initial settings are 30 liters per minute, FiO2 60, and then you increase the flow rate to 60. Maximum flow rate is 60, 70 liters per minute, as tolerated by the patient. Higher flow rates are not tolerated by the patient sometimes. So you have to start from 30, and you have to then see how the patient is doing, and if he tolerates, he or she, then you have to improve to 60. And FiO2 is 60 per minute, 60% initially. And then if the saturation, if you have gone to the highest flow rate tolerable by the patient, the FiO2, then you go on increasing to get the saturation to 98 plus. That is the classic way to do it. Not from a higher flow. The problem with the higher flow setting is patient may not tolerate it. You have to go from a low to a higher. That is the way to do it. That is the best way to do it actually. Okay, ROX index, move on. No. So you have last slide. What have you done? You have said something about ROX score, no?
Sir. Actually, first 2 hours, our ROX score was 3.85, which was within the limits, whereas the next 2 hours, our ROX index has decreased, which is well below the cutoff limit. So, which indicates a failure of high flow nasal cannula associated with there is increased work of breathing. The decision was taken to intubate the patient.
So, Ravi Kumar, doctor, what is the formula for ROX index?
Sir, SF ratio divided by respiratory rate is the formula for calculating ROX index, sir.
Okay. So, any other thing you can look at besides ROX index which may make you intubate a patient on high flow nasal cannula? Supposing the ROX index is normal, can you still intubate the patient? Or do you need to still intubate the patient?
ROX index will give us only the respiratory parameter for intubation or whether to intubate based on only respiratory parameter. We have to see hemodynamics, we have to see the GCS of the patient.
Excellent. So you have to, if the blood pressure is falling or if the patient is becoming drowsy, then also you have to intubate. Okay, so even the ROX index is doing okay. If the patient's blood pressure is falling or if the GCS is becoming drowsy, you have to intubate. Next slide.
What are the limitations of using a ROX index for HFNC?
Sir, if suppose we give a higher than required oxygen, then the ROX index will give us false assurance that the patient is doing all right. So this is one of the limitations where ROX index will be normal, but despite patient deteriorating. So that is one of the limitations of ROX index, sir. And also, as stated before, it will only give us the respiratory parameter, whether it is doing all right or not. The other parameters, it won't say.
Okay.
Okay, Dr. Raghupathi, yeah. Just show with the last slide, you had made some slide. What are that? Yeah. So just keep it there, let the audience see. So yes. This is you can tell the audience what this is.
Yes, sir. Basically, after starting high flow nasal cannula, we used to monitor the clinical parameters as well as the ROX index. ROX index is an indicator of failure of HFNC. So we used to monitor at 2 hours, 6 hours, and 12 hours as described in the major trials. So when the level is below the cutoff level, then it indicates the failure of high flow nasal cannula.
Okay.
Also, you should note that these are the lower limit below which you should intubate. So there is a safer limit like mostly around 4.8. If it is more than that, if it is definitely patient safe to go with the same setting. But if the patient is between those two indexes, so you need to step up your HFNC, either the flow rate or FiO2 to beat the clinical parameter. So these are the limits below which you should intubate. But a safe limit may be around something 4.8. Or in between that, you have to change your parameters as per the clinical things.
This was the major trial, Florali trial, which was published in NEGM in 2015, where they tried high flow nasal cannula against NIV and conventional oxygen therapy. The trial showed there was no difference in intubation rates, but 90-day mortality was there for the high flow compared to conventional oxygen therapy and NIV. But definitely in acute hypoxemic respiratory failure without COPD or other cardiogenic pulmonary edema, high flow nasal cannula will decrease the work of breathing and decrease the intubation rates.
So, what is the mechanism for high flow nasal cannula? Dr. Ravi Kumar, how does it act?
Sir, it has various mechanisms. The high flow which we give is heated and humidified. The heated and humidified air allows us to use the high flow, which we cannot use in other settings like normal nasal cannula. So this heated air decreases the metabolic work of breathing. Second thing, it flushes out the carbon dioxide which is present in the dead space. For the same minute ventilation, patient will have the same can maintain the CO2. For decreased minute ventilation, patient can have maintain the same CO2 as he was maintaining at a higher minute ventilation if you use the high flow nasal cannula. So the work of breathing will reduce. Patient need not have higher minute ventilation. Second thing, with higher flows, it acts as a fixed performance oxygen device. So we'll give the exact required amount of FiO2 requirement. So the hypoxemia also will come down. Hypoxemia will also stimulate the centers for hyperventilation in type 1 respiratory failure. That will also reduce the minute ventilation. And these are the reasons why it will decrease the work of breathing. Metabolic work of breathing, the actual work of breathing, and also patient will have decreased CO2. Increase CO2 clearance.
Does it give any PEEP? You have not said anything about PEEP.
Sir, PEEP, with the mouth closed, patient will have like every 10 liters, patient will get a PEEP of around 0.7. With mouth open, it becomes like 0.35 centimeter of water for every 10 liters. So if mouth is open, it is negligible. But with mouth closed, it gives around maximum of 5 to 7 centimeter water of PEEP, sir.
So most patients keep their mouth open or closed in the ICU?
Sir, mostly they will keep mouth open. There will be air hunger.
So PEEP is negligible. Huh? So what is the role of heated and humidified oxygen?
Sir, heated humidified oxygen, that heat, if we give unheated oxygen with such high flow, there will be dryness in the mucosa. The ciliary beating will be reduced. There will be decreased mucosal clearance. If we give the patient will spend some amount of energy to just heat the air when it passes. So that increases the metabolic work of breathing.
Now,
So
what happens in the airway? If you are giving heated and humidified, how does it help?
Sir, it will help in mucosal clearance. It will preserve the mucosal integrity. The ciliary beating will be.
Secretions become humidified and the patient coughs it out. Secretions are very important, right? They is able to cough out the secretions. That is not there on NIV, right? For NIV is not there. So that is a very big thing. You clear the airways. Apart from that, when you give heated air, it decreases the resistance. It opens up the airways. Heated air opens up the airways and the resistance decreases in the airways. So that decreases the work of breathing also. Okay. So those are in a nutshell the main mechanisms, right? You have said the main mechanisms. The most important is that the CO2 gets washed out. So the CO2 gets washed out from the upper naropharynx and the patient gets a larger alveolar ventilation, right? That is very important. So the patient's carbon dioxide gets washed out easily. Patient feels more comfortable. There's some amount of PEEP. So all this leads to decrease in the patient's effort in the respiratory drive. And the pleural swing decreases. Pleural swing is very important because these patients who are in respiratory distress have large pleural swings, which leads to P-cilia. Okay, that is a very important mechanism. So as the patient starts getting comfortable on this, his pleural swings decrease and the P-cilia decreases, which is a very different from NIV. So what are the differences from NIV, Dr. Raghupati, between NIV differences from high flow?
Sir,
in terms of mechanism.
Sir, generally NIV is more claustrophobic, and since if the patient is drowsy, the patient cannot maintain airway. It can be missed sometimes during the ICU stay. But whereas in HFNC, it is like much of a comfort compared to NIV, and the patient will have a acceptance rate will be much better compared to NIV. Secondly, the airway, if the patient is drowsy and losing the patency, we can immediately intervene compared to NIV. The advantage of NIV is it will give a fixed amount of PEEP, what we said, whereas HFNC, it may not properly delivered, especially when the patient is opening mouth and all. The maximum PEEP also we can achieve up to 6 to 7 centimeters of water. That is the negative side of HFNC. At the same time, the patient can have oral feeds. Patient can communicate with the relatives. Basically, the acceptance and comfort level is better with HFNC. The delivery of PEEP will be better with NIV.
Now, what about pressure support? You have not said pressure support, most important.
Yes, sir. Pressure support, yeah. Pressure support we can deliver with NIV, whereas high flow, basically the high flow which acts as the PEEP support, and there can't be any extra pressure support delivered by the high flow.
Yeah, so that is very important. One, that you can always give a fixed amount of PEEP and you can give pressure support, which is not there in high flow nasal cannula. So in terms of usage, which is preferred now in acute hypoxemic respiratory failure, high flow or NIV?
So high flow nasal cannula is preferred except only in cardiogenic pulmonary edema and COPD. NIV is preferred. Rest all acute hypoxemic respiratory failure, high flow is preferred.
Okay. So this is after the Florali trial where they clearly showed. So
Yes.
if you want to use NIV, at what cutoffs of PF ratio do you not use NIV at all, where mortality is clearly shown to be increased? Is there a cutoff for PF below which you should not use NIV?
Yes.
Ravi Kumar?
Sir, I'm not sure regarding the exact cutoff, but mild ARDS, yes, we can use definitely.
Okay.
Moderate and severe ARDS, it has shown to be harmful.
Correct.
There are a lot of studies in which they have taken a cutoff of around 150. Less than 100 is definitely intubation, but many studies have taken a cutoff of 150 also.
So you should know this, below 150, you should not be using NIV. It is clearly shown to increase mortality. Right? And NIV has never been shown to improve things in acute hypoxemic respiratory failure, especially pneumonia. Okay. But sometimes you may not have high flow nasal cannula, you may have to use NIV. But definitely NIV mortality is increased less than 150, people say even 200. So that is very important. Because one of the essential differences between high flow nasal cannula and NIV is that in NIV, the transpulmonary pressure and the pleural strings don't come down many a times. PCLI is increased. That leads to cytokine-mediated injury in the lungs. While with the high flow nasal cannula, the pleural strings come down, transpulmonary pressures come down, so the injury, the PCLI is much less. That is the biggest difference between NIV and your high flow nasal cannula. All right. So that is the way it is. Okay, great. Now the patient has become drowsy. You have written, now.
And then patient got intubated. So this was the and connected to ventilator. Sorry. This is post intubation. The patient had a pH of 7.38 with CO2 of 48, with PO2 of 72, with saturation of 84%. This was patient immediately post intubation on 100% oxygen. That time, the patient was started with antibiotics, but that was escalated, and then paralysis was initiated. With the patient was started on volume control ventilation with a predicted body weight of 52.4 kgs.
So why fluconazole is given? Is it okay to give fluconazole, Dr. Ravi Kumar?
Sir, here we are suspecting hospital-acquired pneumonia or some lung pathology. Fluconazole may, if we are suspecting any bloodstream infection in patients undergoing upper abdominal surgery or esophageal surgery, would have been justified. I don't think fluconazole is justified in this patient, sir.
Yeah, so you see,
It already started from the surgical ward, so mostly.
So let me just debating. So you see, in any upper abdominal surgery, if the patient develops sepsis after upper abdominal surgery, then fluconazole is very much to be given because there's a very high incidence of canaemia after upper abdominal surgery or even lower abdominal surgery. So GI surgery, patient going post-op into sepsis, fluconazole has to be given because there's a high incidence of canaemia. And one of the ways in which lungs do get affected, pneumonia develops is through bacteremia, or if there's a fungal infection, you can get canaemia. So I think you are justified in giving fluconazole, but if there is canaemia, then one has to look at liver, spleen, and the eyes, because eyes get you have to endophthalmitis, and there can be splenic abscesses and all those things. But definitely, I think fluconazole is okay to be given right now because after abdominal surgery, the patient has developed sepsis in the lungs. There seems to be pneumonia developing in the lungs. So I think it's okay right now. Maybe you can discontinue. So let us see. Okay, and the PCO2 has gone up in your ABG. So why do you think the PCO2 has gone up?
Sir, since this could be looks like primary ARDS, which shows like increased dead space ventilation, which is happening. Secondary to alveolar edema and hypoxemia, which leads to increased VQ mismatch and increased dead space ventilation. That could be the reason for the CO.
Do you think that on just after 2 days the PCO2 goes up? What is the relevance of PCO2 in a patient of ARDS? Elevated PCO2.
Sir, it is explained by dead space ventilation, secondary to the VQ
explanation. I want to know what is the significance, not asking the mechanism. What is the significance of elevated PCO2 in a patient with ARDS?
Sir,
it indicates the severity of the ARDS.
Yes, it is related to prognosis and severity. So do you think after 2 days of just this kind of a picture she developed PCO2 because of ARDS? Ravi Kumar, what is the cause of CO2 elevation here?
Sir, in this patient, I think patient was initially hypoxic, was having a higher minute ventilation due to hypoxemic respiratory failure. Post intubation, the minute ventilation which patient was taking would have reduced because we are controlling the ventilation. So that might have led to the increased PCO2. If it is pre-intubation, then I would say patient has fatigued and it is minute ventilation has gone down. So that is why there is significant increase in PCO2.
So that is the only reason. Either the patient has fatigued or crashed. Okay, type 2 respiratory failure has occurred because of respiratory fatigue and PCO2 has gone up. And if the patient has got hypoventilated after intubation, that is the second reason. This is not ARDS leading to high PCO2. On day 2, PCO2 elevation means that the patient is really bad ARDS. Okay, PCO2 is a prognostic marker in ARDS. All right, carry on.
So this is the new global definition for ARDS described in the last 2023. It says that almost same compared to the Berlin definition when coming to the risk factors and the origin of edema. It may be either primary or secondary risk factors, or we should rule out cardiogenic pulmonary edema. Basically, it's a non-cardiogenic pulmonary edema, which is acute in onset. Timing is as usual, which is less than 1 week. In the chest imaging, they included ultrasound in the low resource settings, which can be used to rule out, as usual, effusions, atelectasis, and nodules. And they classified ARDS into non-intubated ARDS and intubated ARDS and resource-limited settings. Non-intubated ARDS, most of the time, the patient with HFNC or NIV with PEEP of 5. Intubated ARDS is almost same as Berlin's definition. And in resource-limited settings, they included the SF ratio with saturation less than 97%, where there is no requirement of PEEP or no requirement of PEEP is required in a resource-limited settings.
So, in a nutshell, what are the changes, Dr. Raghupati, in the new definition?
Sir, actually, they included poor resource-limited settings. They included Kigali modification, which says like SF ratio, it can be comparable to the PF ratio, where the ABG machines are not available. Secondly, in the imaging part, usually it was described classically for chest X-rays.
In resource-limited countries, not only in a resource, SF ratio can be used anywhere. Okay, it's not resource limited only. In the SF ratio is the first difference. It can be used anywhere because the SF ratio has shown in trials to be equally good as PF ratio. And you don't have to do ABGs, repeated ABGs. So first difference is SF ratio can be used instead of PF ratio provided saturation is less than 97. Because other than that, because if the saturation is more than 97, your PO2 can be very high. So it does not correlate. One. Second, in resource limited ICUs with really no facilities, if the clinician thinks that the patient has respiratory failure, hypoxemic respiratory failure, then SF ratio alone is sufficient to classify as ARDS. Okay, that was the second difference. Third difference is ultrasound can be used to diagnose ARDS now. Okay, it's not only X-ray and CT. Okay, and the fourth difference what is the fourth difference? So what is the fourth difference? One more difference is there.
Without the use of any PEEP.
Yes. So now the fourth difference is PEEP is not necessary, and that is because high flow has come into picture. Okay, so these are the four differences which have been introduced. Okay, the PEEP is not necessary, and that is actually more for high flow nasal cannula, not really for the other things. And because these changes have come in the last few years, that is why the need for new definition. Okay. Now, one more question to you, Dr. Ravi Kumar. Is PF ratio directly correlated with the severity of the lung disease in ARDS?
Yes, sir. PF ratio correlates with severity. Lower the PF ratio, higher will be the mortality, sir.
Supposing I change the vent settings for the PF, then will it not change PF?
Yes, sir. That can vent settings itself can change the PF.
Yes. So that's the problem with PF. PF does not directly correlate. PF is dependent on the vent settings. Okay, so PF ratio is changeable. You know, if you change the vent settings, your PF will change. So on the same patient, same condition. So PF is also very loose kind of a parameter. Then are bilateral infiltrates necessary, Dr. Raghupati, or unilateral infiltrates you can diagnose?
Sir, classically described as bilateral, but in most of the pediatric ARDS, they describe even unilateral infiltrates also. It could be comes under ARDS. It's a lot of publications, and even in pediatric critical care, they describe the unilateral infiltrate. They will take as ARDS.
So why these people have not included unilateral in adult pediatric ARDS? Why do you think we are still persisting with bilateral infiltrates? You think unilateral infiltrates will not cause ARDS? Why is that they are not including by unilateral infiltrates?
Unilateral mostly in adult settings, we will just take it as a pneumonia consolidation or collapse. But whereas ARDS will be more of a generalized systemic inflammation which is happening, and that's why it's mostly traditionally described as a bilateral infiltrates. Because in most of the patients, we do see bilateral diffuse infiltrates only.
No, sometimes you have a unilateral pathology with PF less than 300. So can we not call that ARDS?
It could be early phase may possible, sir. There will be a unilateral, then it will progressively goes to bilateral. But early phase may definitely unilateral also possible.
The pediatric group has now included unilateral from this definition.
Yes.
So this is a matter of debate actually. This is not clear. They have debated over this, or the jury, the people or the group who frame these guidelines. This is a point of contention. Should we include unilateral infiltrates? And why did it not include is one, because all along, all these studies done so far, they have looked at bilateral infiltrates. One. Second, when they want to give recommendations for the vent settings, etc., PEEP settings, they want a clear severity, and unilateral is less severe than bilateral. So that becomes a problem. Third, unilateral etiologies are different. Unilateral can have very different kind of etiologies. So these were some of the points that were discussed. Okay, and one is, they have to have a lot of clear homogeneity in the kind of patients they are going to choose to set guidelines. And when you choose unilateral, things become very inhomogeneous. So these were some of the points that were discussed and why we are still including bilateral. Definitely unilateral is less severe. Unilateral will not classify generally as severe ARDS. That is, you understand, those are the problems. Everything will become topsy-turvy if we include unilateral infiltrates. Okay, so I think for the audience, these are the new points in the new guidelines. Everybody should be aware of them. And you can use SF ratio and you can use ultrasound to diagnose and so on and so forth. 4 changes that have occurred in the new definition. Okay, Dr. Raghupati, carry on. Dr. Kumadi, yeah, move
Yes, sir.
on.
Yes. So, coming to the workup,
Just,
after
just 1 minute, just go back. Just go to the initial vent settings. So I think we have to tell this. So have you told the vent settings?
sir, I'm just coming, sir.
Okay.
So, basic workup has been like routine investigations has been taken, and mainly the cultures from the blood, the ball, and the urine has been sent. Abdominal rain cultures also sent, and to rule out other infections like TB, fungal infections, galactomannan, gene expert, and AFB also sent, and urine routine and procal also sent.
So gene expert is for what?
Sir, it's basically a PCR-based assay for tuberculosis. Since the patient is immunocompromised coming from a low socioeconomic status, in Indian scenario, TB should be ruled out before seeking for other fungal or other bacterial infections.
So does TB cause ARDS?
Uh, yes, sir, TB will cause ARDS, sir.
Okay, TB can cause ARDS there, but it can cause ARDS. So galactomannan is for what?
Galactomannan is a biomarker, fungal biomarker, which is mainly used to it's a fungal biomarker to rule out fungal infections.
So do you think she can have fungal hair? And
Since the patient has risk factor for fungal infections and there is an infiltrates predominantly on the one side, and the patient has risk factors, so it's better to rule out fungal infections. Since the patient is already on antifungal, it will give a picture whether we can continue antifungal or we can stop it also.
So which fungus is made mainly for galactomannan?
Galactomannan, aspergillosis pneumonia, and mucormycosis will have a will leads to a rise in galactomannan levels.
Okay. So what about the role of BAL in this patient? Do you think BAL will come positive? What are chances that BAL will lead a positive culture in this patient?
Sir, per se, BAL have a yield of only sensitivity of about 40 to 60%. Since the patient is already on broad spectrum antibiotics, there is only 40% chance that we may get some uh, positivity from the BAL culture. Otherwise,
Dr. Ravi Kumar, if the patient is already on antibiotics, what is the yield of BAL?
Sir, if you have targeted, if you have given proper antibiotics, around 20 to 30% yield, sir.
Yeah, it is even less. It is only 15%.
The diagnostic method at the bedside to prove it is a pneumonia. Basically.
So what else can increase the yield, in terms of etiology of the pneumonia? What can be said? What additional test will increase the sensitivity of the testing that we are doing to get the etiology of the bacteria, if there is a bacteria?
Sir, definitely BAL has the highest sensitivity compared to the sputum and ET secretions. And we can do it like since the patient have a right lower lobe pneumonia, we can go and take the sample from the right lower lobe. And before starting antibiotics, and especially if the patient have a high sputum secretions, then definitely that will increase the yield of the BAL culture.
No, that is okay. BAL should be done. We should always do BAL in patient who's admitted to the ICU and sick. But what test can we send in BAL to increase the yield? Anything, any test you can send?
PCR.
Yes, we can send PCR. So wherever possible, try to send PCR. The yield of PCR is much higher. It is a very good test now. And the greater number of bacteria you send, the greater the yield. So PCR is a very good yield, and antibiotics do not influence. That is the biggest thing. So PCR done properly, BioFire, and so which is the best one probably as of now, to my knowledge. If you can send, if the affordability is there, and actually the affordability does not matter because the cost effectivity is very good. Okay, because the yield is very high. The ICU stay becomes less. You save the life of the patient. You get the etiology. Huh? So PCR should always be considered. Don't forget PCR. Wherever possible, send PCR. And not you guys are all at AIMS, so the AIMS is the that's the biggest lab. But even outside, anywhere, wherever possible, send PCR in bulk. Huh? It is cost effective. It costs around 15,000, I think, even in private lab centers, but it is cost effective in the long run. Okay, next.
So coming to the ventilator settings, the patient was initially started on 100% oxygen with tidal volume of 5 ml per kg, 260 ml, respiratory rate of 30, PEEP of 12. With that, the patient had a compliance of 14 mils per water, plateau pressure of 32, driving pressure of 20, with IE ratio set at 1:2. With this, the ABG showed PF ratio of 75.
So, Dr. Ray, sir, so one thing, please, if you can tell the audience, we have a lot of young students and everything, how to actually set the ventilator after you intubated and put him for ARDS. So, please, if you can tell the audience once.
Yes, sir. Mostly we will prefer either volume control or pressure control ventilation. Generally, here.
Dr. Ray,
Yes, yes.
आप एक बार audience को बता दो, please, how to set the ventilator after they get intubated and the patient has ARDS, step by step.
No, normally, what has been followed for a ventilator setting in ARDS is you follow the ARDS net protocol for the tidal volume. The tidal volume is normally set as a lower tidal volume between something between around you start at 6 ml per kg of the predicted body weight. You calculate the predicted body weight and start with the 6 ml per kg body weight. Then coming to the PEEP setting, there are a lot of debate how to use. Traditionally, the PEEP table has been used, but nowadays a much more individualized approach is used. Rather than using any formula or table-based PEEP approach, you can go along with the titrating the PEEP to have a better compliance or to target the plateau pressure which is less than 30 and a driving pressure around 15. So most of the time, individual approach is much more better. The targets are plateau pressure should be less than 30 or preferably 28, and the driving pressure should be around 8. So you target your target volume and the PEEP to achieve these goals. FiO2 setting, normally as per the demand, you start something with the higher FiO2 and decrease it. Target is something around 88 to 92% of saturation you target. That is good enough. And normally, as per this is the initial setting you start ventilating the patient with ARDS. Then, as per the requirement, you modify other things like the IU ratios or the tidal volume if you want to decrease or how much CO2 is decreased, like that. You basically.
Okay. Thank you, sir. Thank you very much. So now, Doctor, what do you want to say in this slide? Is this slide over, Dr. Raghupati? You are telling something.
Sir, this after initial mechanical ventilator settings, the patient had a PF ratio of less than 100. So we after paralysis and optimizing the PEEP, we made a decision to prone the patient. The second box on the right side, which is 5 hours after post proning, the CO2 is like 56 to 50. And the oxygenation, it's almost on the same 75 and 78. This was the first session of proning, and then this was the ABG, which was done 5 hours after the proning.
Okay.
So are you think this is a responder or non-responder?
So since the CO2 has come down of 6 millimeters of mercury, we can say patient is a prone responder, sir. But
What is the criteria? What is the criteria to say that is a prone responder?
Sir, either PF ratio, there is an increase in PF ratio of 20% or 20 millimeters, or a drop in CO2 levels of 1 to 2 millimeters from the baseline, which can be considered as a prone responders. Usually, it may be either early or late. Early, which is occurs mostly less than 4 hours. Late, usually they will respond more than 4 hours. And persistent and non-persistent prone responders. Persistent, which usually they will maintain the PF ratio even after the turning the patient to supine, whereas non-persistent responders who usually maintain the PF ratios in prone position, they will drop the PF when the patient is especially on supine position.
So, Dr. Raghupati, compliance, right? What is does the best PEEP correlate with best compliance?
Sorry, sir.
Does the best PEEP correlate with best compliance?
Sir, actually, we can optimize the PEEP by checking for driving pressure or compliance. Usually, we will start at the lowest PEEP possible, like let's take 5 to 8 centimeters. We will either grow incrementally or decrementally. Usually, we will go incrementally at 2 to 3 centimeters of increments, and then we will assess the compliance and the driving pressure. The once the PEEP reaches the, we can also see it in the pressure volume loop. Once it reaches the uh, higher the inflection point of the lower inflection point, then we will have the high compliance will be much better, and then driving pressure will be lesser. So we will gradually increasing the PEEP level to attain the maximum possible compliance and maximum minimal driving pressure. And once we achieve that level, we will further increase, and then if we will reach one point where the compliance will decrease, our driving pressure will increase. So we will just keep the PEEP at the at the previous setting generally.
No, that is okay. But when you use driving pressure, is driving pressure more useful as a tidal volume or PEEP?
So driving pressure we use mainly for PEEP.
That is not correct. Driving pressure used is actually more for setting tidal volume. Okay. And best PEEP does not correlate with best compliance. Do you know of any trial, big trial, which has shown this, where compliance was correlated, tried to be set according to PEEP?
Yeah, actually, yes, sir. This respiratory rate, tidal volume have a exponentially increase with increasing.
You answer what I'm asking clearly. Dr. Ravi Kumar, do you know any trial which tried to show that best PEEP and best compliance go hand in hand? And the result was that the best PEEP is not the same as best compliance. Are you aware of the trial? It's a very big trial.
I'm not sure, sir.
So this is the ART trial, ART trial. Okay, this was a trial, very big trial over 6-7 years. It was conducted, and they tried to correlate that the best PEEP is best compliance, and they saw that the best PEEP is not best compliance. Okay, second point, when you use driving pressure, it is more for setting tidal volume, and it is not for PEEP. Okay, PEEP is more like what Sir has said. You try to maintain the plateau pressures. And what is high PEEP and low PEEP?
Generally, there is a no cutoff value has been described. High PEEP is generally anything more than 12 to 15 centimeters is considered as a high PEEP, which indicates there is a more recruitability of the lung. Whereas low PEEP is generally 5 to 8 centimeters of water. But it's almost, we can say it is equivalent to the low tidal volume and high tidal volume, which was described earlier. But there is no clear-cut cutoff for the high PEEP and lower PEEP at present. It is like generally a more like a personalized approach rather than a individual.
Where do you use high PEEP and where do you use low PEEP?
So high PEEP we use usually in a moderate to severe ARDS where we will have a highly recruitable lung. We can go for a high PEEP. Definitely that will increase the compliance of the lung. Whereas in mild ARDS, it is better to use a low PEEP where there will be a no recruitable lung.
Okay, so that is correct. Low PEEP is anything less than 10, 12, and high PEEP is more than 12. Okay, there is no cutoff, but that is the general, consensus in world literature. And for moderate to severe, you use high PEEP. For mild ARDS, you use low PEEP. Okay. Now, the other question is that what is the formula for compliance?
Sir, compliance is the change in volume over the change in pressure is usually the expired tidal volume divided by the plateau pressure minus PEEP, which is usually the static compliance, whereas the dynamic compliance is a peak pressure minus PEEP in the denominator.
So what happens to compliance in ARDS?
Compliance usually will goes down. It correlates with the severity of the ARDS. When there is the higher, more severe the ARDS, the compliance will be much lower.
Okay, so why does compliance decrease?
Basically, the alveolar edema, interstitial and alveolar edema, along with the atelectasis in the predominantly in the peripheries and the basal regions, which leads to low compliance of them.
Okay, so what is the target plateau pressure for ARDS ventilation?
So generally, recommended is less than 30 centimeters of water.
Can you go higher in certain patients?
Generally, it is not recommended since, but specifically in patients like obese or like restrictive lung disease or any chest wall deformities, plateau pressure may be high. Since it may be falsely high, in those subset of patients, we can go slightly higher. but there is always a chance of barotrauma with high plateau pressure more than 30.
No, in restrictive lung disease, you can increase the plateau pressure.
No, sir. Generally, there will be a falsely high plateau pressure. So, on targeting it,
There is no
better.
1 minute. There is nothing like falsely high plateau pressure. Plateau pressure is plateau pressure. You're getting a reading. So in restrictive lung disease, what will happen? You want high plateau pressure or low plateau pressure?
So, since the chest wall deformity and the chest wall compliance will be less, and say, especially in obese patients and all, with increased intra-abdominal pressure, in those subset of patients, because the intra-abdominal pressure will be reflected to the intrapleural space and the transpulmonary pressure will be falsely high. So that may sometimes show as a high plateau pressure when we measuring. So in those patients, we do accept a high plateau pressure over a 30. Whereas in other patients, we generally set less than 30 by adjusting the tidal volume and respiratory rate.
So Dr. Ravi Kumar, in which patients will you increase plateau pressure more than 30?
Sir, obesity will be my first
Okay.
answer for.
So in obese, so how do you do it? How much, what is the upper limit?
So there's no defined cutoff as such. The ideal way to set a PEEP in such patients will be to use esophageal pressure monitoring.
That is not there most of the times. So how much upper limit will you set in obese patient?
Maybe go till 35 centimeter water, sir.
Maybe is not the answer. You have to be more precise. How will you set it? What will happen if you increase the pressures? What else will happen?
Sorry, sir.
Once you start increasing the pressures, one is barotrauma, right?
Yes, sir.
What else can happen?
There can be hypotension.
Yes. So your pulmonary vascular resistance increases, your venous return decreases. So you look at the blood pressure. One is your barotrauma, the other thing is you look at the blood pressure. Blood pressure will start falling. If your pressures are going high and then your blood pressure is falling, you cannot increase the P-flat more than that. Okay. So the one thing, when you do the ventilation, always keep an eye on the cardiac output because the cardiac output also has to be good. The ultimate aim is one is to prevent lung injury, second is to give oxygen to the tissues. Okay, so when you increase the pressure, when you put the patient in positive pressure ventilation, your cardiac output generally decreases. How will you make out if the cardiac output is adequate or not in these patients? Dr. Ravi Kumar?
Sir, blood pressure, we can measure capillary refill time.
Capillary refill time is not the answer here. The patient is not really in shock and all. You can't. Capillary refill time is not the correct answer. How will you objectively?
PTI on an echo, sir.
That will tell you only cardiac output. That will not tell you adequacy of the cardiac output. Cardiac output is not the number that you want. You want adequate cardiac output. Whether your cardiac output is adequate when you are going to high pressures on the ventilator, how will you assess?
Lactate levels will.
Lactate levels can take time, many hours to rise. They are slow. What else? Raghupati? You are setting the ventilator, you are worried your cardiac output is falling, you're not sure. How will you assess?
Sir, first, pulse pressure we'll see, sir. And then if there is any unexplained tachycardia with the pulse pressure is narrowed.
You are not going to be there.
Anything with the microcirculation, you have to, whether the circulation.
Fall in urine output or like.
No, urine out, those are not the things. How will you assess oxygenation? What are the ways?
CO2 gap we can see in arterial and venous blood gases.
CO2 gap before that, something more simpler. How do you assess oxygenation? One is lactate, one is microcirculation, but what is the most precise way here?
Sir, then the patient saturation we can see, sir.
Yes, saturation, what saturation?
Sorry, sir.
SCVO2 will fall, sir.
Saturation gap you have to see. Saturation gap.
Okay.
The saturation gap will increase, right? That means the extraction is increasing. Normal extraction is, so the difference between your arterial saturation and venous saturation is 25%. Yes. Provided the oxygen saturation in the arterial blood is good. And if this is increasing to like 30, 35, that means more oxygen is being extracted. That means cardiac output is falling. All right. And the other things also can help, but this is the most precise way. One has to be aware of cardiac output when one is going to high pressures, something which don't see in the ICUs or our ICUs. Ultimately, there are two goals to ventilation in ARDS. One is you should not cause injury. Second is you should be giving enough oxygen to the tissues. All right. So now driving pressure you have mentioned P peak, P plateau. Is it important to look at only P plateau or P peak is also important?
Sir, P plateau is more important since it's an indirect indicator of the compliance. Whereas P peak definitely if there is any resistance component is there, it will give you the if there is any obstruction or secretions or like any bronchospasm associated with ARDS, P peak also important, sir.
So is there increased airway resistance or normal airway resistance in ARDS?
Sir, generally it will increase the airway resistance, but predominantly the main component is the increased plateau pressure.
So Raghupati, just being specific, is the airway resistance increased or normal?
Definitely, if the compliance goes down, that resistance will be increased, sir.
So the compliance is different from airway resistance, right? Compliance is in the lung parenchyma, airway resistance in the airways. So Dr. Ravi Kumar, what is the answer? Is in ARDS, is airway resistance normal or increased?
Airway resistance will be normal in ARDS, sir.
You are wrong, both of you. There is a slight increase in airway resistance in ARDS also. Please read about it. Huh? Okay, ARDS, the resistance, airway resistance is increased. You cannot have isolated pulmonary pathology. And there is even airway closure now described. So many things are there. Please read about it. Okay, next slide.
So this is a basic mechanism of proning, which will helps in increasing the oxygenation and decreasing the ventilator-induced lung injury. When the patient is in supine, there will be a disproportionate inflation of the alveoli. Most of the alveoli in the upper part will get over distended, whereas in the dorsal areas will not be recruited, and there won't be any ventilation. Whereas when the patient is prone, there will be a shift in the oxygen ventilation to the dorsal areas, and then there will be a homogeneous ventilation and perfusion. So it will decrease it will recruit more alveoli and increases the compliance and decreases the ventilator-induced lung injury. And also it helps in increasing the oxygenation also. In this way, proning followed by paralysis will have a mortality benefit up to 60% in almost 500 patients. This was the trial which was published in 2013. Neuromuscular blockade. Usually, we used to give neuromuscular blockade during the early phase of ARDS, which is less than 48 hours. Generally, recommended is will give only bolus doses. But during the first 48 hours, if the patient is not able to ventilate, there is any lot of asynchrony, which will further worsens the ventilator-induced lung injury. We will paralyze the patient with cisatracurium preferably for almost up to 48 hours.
So is it compulsory to give? Does it decrease mortality? What are the current evidence and guidelines on neuromuscular?
Sir, neuromuscular blockade, initially, the trial in 2010, Accurasis trial, they showed mortality benefit, stating the reason like the neuromuscular blockade will decrease the inflammation induced by the ventilator-induced lung injury, thereby having a mortality benefit. But it is not validated in further trials. The ROSE trial, which is the latest, which showed there was no difference in patients receiving neuromuscular blockade versus light deep sedation. So, there will be a lot of side effects also with neuromuscular blockers, like critical illness myopathy over the long term. So it's better to give neuromuscular blockade as a bolus doses when and of needed, especially when the patient is having high ventilator dyssynchrony.
So how does it help neuromuscular blockers? What does it do?
So, generally, it will prevents the ventilator dysynchrony, and it will have a better ventilation.
Also decreases the oxygen consumption. That is also important. Decreases the oxygen consumption. Okay, and causes critical illness, myopathy. So use it SOS. Use it SOS. Bolus doses. Okay. Move on.
So, this is the chest X-ray, which got worsened compared to the initial X-rays, almost bilateral diffuse infiltrates, predominantly on the right side. So after day 2, she was on 80% FiO2 with a tidal volume of 250, with plateau pressure of 27 and driving pressure of 15. That time, the PF ratios was 143, which was increased from 70s to 140s. But the patient was supine. Post supine, again, the PF ratio was dropped. The PF ratio again dropped after supining the patient, dropped to less than 100. After second session of proning, the PF ratio has increased to more than 200s. Since the X-ray has showed right whiteout of the right lungs, the bronchoscopy was done. There was some secretions present in the right mid-zone and lower zone in the intermediate and secondary bronchus, which got aspirated and sent for ball samples. And the patient was initiated on TPN for the calories nutritional support. Steroids were started, and the patient was supined after 18 hours after the second episode of proning.
So, what is the current role of steroids in ARDS?
Sir, steroids definitely in severe ARDS, it is recommended. The agent is still controversial. Preferably dexamethasone, which is used in the major trial DEXA-ARDS, which has some benefits decreasing the inflammatory phase of the ARDS. Or as we can go for methylprednisolone, 1 mg per kg per day, and it can be given for first 5 days, and then we can taper after the next 5 days. Regarding the timing, there is no clear-cut indicator, but it should not be given more than 14 days. There will be a harm in initiation of steroids after 14 days. Steroid is recommended, not recommended in mild ARDS. It is definitely recommended in moderate to severe ARDS.
So, Dr. Ravi Kumar, anything you want to say on steroids? What is the trial he has told? Is the DEXA-ARDS trial. And apart from the DEXA-ARDS trial, just around that period, there was a major meta-analysis that also showed benefit. Okay. So now the recommendation he has said is 10 milligram per day of dexamethasone, right? So anything else you want to add to that, Dr. Ravi Kumar?
Sir, there are trials for prevention of ARDS also. Those have shown clearly harm in patients.
Not prevention, just this now. He has said that this is the current recommendation, which is correct. Now, you want to add anything to this recommendation? What he has said? Any more details? So you can use either methylprednisolone also, or you can use hydrocortisone in equivalent doses. And the duration is around 10 days. And it should be initiated early as the patient is getting bad as soon as he gets intubated. All right, that is the current recommendation. And around 10 days, there is no fixed dosing. There is no fixed duration. Dosing is correct, 10 milligram per dexa per day, or equivalent, any other steroid can be used. And the duration is around 10 days. You use it as per the clinical situation. So use DEXA in ARDS as soon as the patient gets intubated or is getting intubated. All right? And how does it help? How does the steroids help? What is the mechanism of action of steroids in ARDS?
Sir, basically it decreases the inflammatory phase of the ARDS, which is usually in the first week of ARDS. Usually the patient will have a pro-inflammatory cytokines, which leads to higher capillary leak that will be decreased by the ARDS. The non-cardiogenic pulmonary edema, and it will help in increasing the compliance of the lungs.
Okay. Next.
Another thing, previous slide. So supine for around 16 lessons. Is there any role of extended duration of proning?
Yes, sir. Actually, most of the trials, the minimum duration recommended is 16 hours. There is a no cutoff for the higher duration. People have tried almost up to 48 hours, up to 72 hours. There even one case report has showed for 4 days they didn't have any major complications associated with proning. So higher the proning duration, there will be a better chance of recruitment and better prevention of ventilator-induced lung injury.
Now, in a nutshell, Dr. Ravi Kumar, what are the results of extended pruning? In just simply, what are the results of data on extended pruning?
Sir, extended proning used in patients with severe ARDS where the chances of Willi is high. In such patients, extension of proning reduces the Willi, increases the recovery in such patients, sir.
But is there any benefit, definite benefit compared to the harm of using extended?
Generally, the number of episodes of proning will come down, sir.
No, actually,
Common sense, what will happen if you prone for a long time? Suppose you give the patient for 36 hours, what will happen?
Better recruitment of the lung will be there, sir.
And what will be the side effect? Any side effect?
So the compression injuries.
Yes, that is what is happening.
Use of paralysis will be for a longer time.
Paralysis, the patient will get bed sores. There are no prospective studies on long-term, long sessions, okay, more than 16, 18 hours. We have retrospective data which has shown that the lung outcome is better. Earlier extubation and all that happens, but at the same time, pressure injuries is more. Okay, so you have to individualize here. You can go for longer time. There's no problem if the nursing care is good. But if you're increasing the session duration, you are going to get more bed sores. That is, you have to take care of that. That is, and what about awake proning? What is the data on awake proning?
Sir, it is recommended. Mainly, it was tried during the COVID ARDS. Basically, it will prevent the intubation. Whenever the patient is awake and having a hypoxemic respiratory failure, whenever the patient is cooperative, we can do awake proning to prevent intubation and have a better recruitability and a long.
What is the evidence? What does the evidence now say on the results on awake proning? The data is there. People have studied. What is the data? Does it help? Does it reduce mortality? Does it reduce intubation? Does it worse? What does the evidence say?
Sir, evidence says there is no mortality benefit. Definitely decreases the intubation rates.
Very good. That is all there is. There is possible mortality benefit also, which has not emerged in the data, but definitely it reduces intubation rates, and it should be done with high flow because with NIV it is very uncomfortable for the patient. So do awake proning with high flow. It definitely reduces intubation and possibly it reduces mortality. And the session should be at least 8 hours. At least 8 hours, patient should be getting high flow. Sorry, awake proning, not less than that. Less than 8 hours, it does not help. That is also important. Okay, move on.
Yes, sir. So,
so driving pressure, you are not sure. You are showing, yeah.
Yes, sir. So this was the trial which was retrospectively taken from the previous 5 to 6 trials in ARDS. They checked the driving pressure of those patients and they found that it was correlated with mortality because whenever the patient had an increased driving pressure, it is associated with mortality in moderate to severe ARDS. So it's current recommendation is it's better to maintain the driving pressure less than 15 centimeters of water.
Next slide.
So apart from thrombocytopenia, there was a day 3 after intubation. There is some amount of clearance of the infiltrates.
Video. I think there's a problem with the transmission. Your frequency is not bandwidth is not good enough. Just switch off a video. because you are getting frozen. Yeah. Switch off the video. Just go audio only.
So this is the X-ray on day 3 of ARDS. There is a after proning, second session of proning, there is a clearance of infiltrates predominantly on the right side, up mid zone and the upper zone. The CT was taken after the patient was supine. There was some amount of pleural effusion predominantly on the right side with diffuse ground glassing opacities. With there is a peribronchial consolidations and yeah, that is the significant thing. It's more likely a basal effusion with diffuse bilateral GGVs.
You have the CT report?
Yes, sir. Sir, actually, report actually there is I couldn't get the official report, sir, but whatever written in the file, it is like a right-sided pleural effusion of 3 centimeters with bilateral diffuse ground glassing opacities with peribronchial consolidation, mainly in the right upper and middle posterior lobes, associated with there is a crazy pavy pattern in the left and right mid zones.
So, Dr. Ravi Kumar, is this a classic ARDS CHCT?
No, sir, this is not a classic ARDS CT. The classic ARDS CT will have apicobasal gradient and anteroposterior gradient with respect to the infiltrate, sir.
Yes, so this is a slightly unusual picture. Patient was extremely hypoxemic. So I'm not able to understand why she got so hypoxemic. Even after intubation, she was hypoxemic. You know, there was severe hypoxemia. PF was 70, 80. So a little difficult to say, but I think I'm not sure whether there was some element of pulmonary embolism in this patient. Dr. Bikash Kaur, any comments? Because this is not.
Rakupati, this is the CT after proning or before proning?
Sir, this is after proning, sir.
So one explanation maybe, sir, maybe there is a previously the gradient was there, but after proning, it has cleared up. But otherwise, yes, what you are telling is correct.
Yeah, so yes, after proning, but you know, the other thing is this is just day 2, day 3, and this is after proning, so there was not enough time also for the gradient to develop and you know basal haziness. Yeah, you have had the patient very early, right in front of you, so that may be another reason, and you have prone the patient. So that may be the reason why the CT is not classic. You know, early disease and after proning, so maybe because of that. But possibly there might have been some pulmonary embolism also. I'm not sure whether about pulmonary embolism. Cannot rule out. And you know, sometimes what happens is there may not be too much of opacities, but there may be severe perfusion difference. Perfusion is impaired markedly. So when the perfusion is impaired markedly, it will not show up on the CT. Even if there is no opacity as such, not much opacity, if the perfusion disturbance is significant, then also you will get very severe hypoxemia. You know, you can have two patients with the same CT, but the PO2 will be different because it depends on the perfusion. If the perfusion is good in one patient, so VQ matching is good, your oxygenation will be good. But if the perfusion is impaired with the same kind of CT, your VQ will be more severely impaired and you'll get severe hypoxemia. So I think there might have been a severe perfusion problem also in this patient. And maybe there was some pulmonary embolism, I cannot say.
Maybe.
Next.
She was supined after second proning session. PF has improved to 245. So paralysis and sedation has stopped. GCS was full. So antibiotics was continued and she was started on FJ feeds. This was then she was after volume control ventilation, she was taken on APRV mode with 40% FiO2 with T high of 26 and T high of 2.6. With that, she was generating tidal volume of 280 ml. She was maintaining PF ratio around 210. With this, ABG showed almost CO2 of 52 with PO2 of 84 with 40% FiO2.
So how do you set up a APRV in the initial stage? What is the initial setting? How do you start APRV mode?
So first, in volume control ventilation, we will measure the plateau pressure. That will be the P high. And the inspiratory pressure, the maximum is like we will set 20 to 50% of the inspiratory pressure demand. And then P low will be usually we will set it at 0. T high and T low will be mostly depends on the CO2 levels. And preferably we will keep 3 to 4 seconds of T high, and T low will be 0.5 seconds generally. With that, we are able to generating a tidal volume of 5 to 6 ml per kg, and then able to maintain the normal oxygenation to maintain the normal oxygenation.
Okay.
Then APRV, the patient was continued and the oxygenation FiO2 was weaned. So the patient maintained the saturation and PF ratios, and the plateau pressure also came down to 22. From APRV, the patient was weaned to pressure support ventilation with 35% of FiO2 with pressure support of 11/7. With that, the patient was generating around 300 ml. She was almost the PF ratios were normalized. With AVG showing almost a CO2 of 38 and normal lactate and bicarbonate. So gradual weaning of pressure support was done, and she got extubated to high flow nasal cannula with the 30% oxygen. Then she was weaned to nasal prongs, and during that time,
One thing, Rakavati, what is the current recommendation regarding extubation to HFNC or NIV? So do you use this in all patients, or is there any specific subset of patient you should extubate
yes.
to NIV or HFNC?
So the patients we can individualize, like if the patient having any risk factor for respiratory failure post extubation. In those subset of patients, we can consider HFNC or NIV post extubation. Examples like any patient with like cardiac failure, like diastolic dysfunction, or like weaning difficulties. Already the patient have a prolonged or a difficult weaning, or the patient is specifically obese patient, and the patient have a high intra-abdominal pressures with
I think there is a bandwidth problem with this thing, Wi-Fi. So, Dr. Ravi Kumar,
can consider HFNC.
yeah,
But routinely to HFNC is not recommended when there is no risk factors for respiratory failure.
So, Dr. Ravi Kumar, carry on. We'll finish. I think you're coming to end. Carry on. Dr. Raghupati?
Yes, sir.
Rakavati, carry on, huh?
Sir, audible, no, sir.
No, carry on.
Yeah.
Yes, sir. These are the X-rays on the day 5 and day 6 post ARDS. Almost there is a clearance of chest X-ray infiltrates. This was the X-ray after ICU discharge. Investigations, the patient's thrombocytopenia and INR are all normalized. There is no other organ dysfunctions. But during the course of ICU stay, the ball culture came sterile, blood culture also sterile. But there was a wound culture which showed one is E. coli, the second one has grown Acinetobacter, which is resistant to carbapenem. Otherwise, blood, ball, and urine came sterile, and antibiotics were appropriately escalated for the Acinetobacter.
No, 1 minute, just go back. So, do you think the patient actually, you can say whether the patient had E. coli infection or crab? Can you say on this when you're getting different organisms from different sites?
Generally, drain culture, whenever this is recommended mainly during the intraoperative samples, our drain culture has to be taken less than 12 hours of drain insertion. So anything more than that could be a colonizer. Secondly, anything more than could be possible, sir, polymicrobial, but since it is taken 21st and 27, there will be a possibility of growing 2 different organisms. Secondly, it is not recommended to take to check for drain cultures more than 12 hours of drain insertion. Most of the time, it will be a colonizer.
You are correct to drain, okay? So drain culture sensitivity has no meaning beyond 12 hours. But the point I'm trying to make is ball is sterile, blood is sterile, and you are getting the drain, and also I don't think that you can say that this is a crab that has to be treated here. You don't know what you're treating, okay? You just have to cover, and the patient is recovering. So to say from the microbiology here that crab is causing your pneumonia is wrong. You cannot say that. You don't know what you're dealing with actually, right? Frankly speaking. Okay, now the next slide. Is it all?
Yes, sir. That's it.
Last slide. Okay, great. You can put your video on. Thank you. So now just before we finish off, Dr. Raghupati, put your video on.
Yes.
So, Dr. Ravi Kumar, this one like post-extubation respiratory failure within 72 hours, the patient worsened. So, in this situation, should we actually go for high flow nasal cannula or NIV?
Sir, patient has worsened. Patient has worsened. We have to like directly go ahead with intubation rather than putting the patient on NIV or HFNC.
No. How much time did you put high flow nasal cannula?
Sorry, sir.
Initially, when she worsened, she was put on high flow nasal cannula, right?
Yes, sir.
So there are differences like we discussed between high flow nasal cannula and NIV.
Yes, sir.
Do you think high flow you could have done better with NIV probably?
Sir, I don't think so. High flow is still better in this patient also, sir. There was no atelectasis as a cause. We were not suspecting atelectasis as a cause for respiratory failure. If it was our first primary differential, then we, like with use of NIV for quite some duration, only patient would have recovered well. But we were suspecting hospital-acquired pneumonia as a cause of like acute hypoxemic respiratory failure as a primary differential. So I would still think HFNC was a right choice.
Okay. So what are the recommendations for post extubation respiratory failure? Do you go for NIV or do you go for high flow nasal cannula?
Sir, if it is frank respiratory failure, no need, neither of that is recommended. Go directly for intubating the patient. For prevention, yes, either HFNC or NIV is recommended, sir.
You are correct. But if the patient is developing respiratory failure, you don't intubate directly. You can have a trial. So what do you go for? A high flow or nasal cannula or NIV? So you don't have. Sometimes you have the option, right, of going for some supportive treatment rather than going for intubation. So if the patient has post-operative respiratory failure or impending respiratory failure, early respiratory failure, then what do you use? Do you go for high flow or do you go for NIV?
Sir, high flow is recommended, sir.
That's incorrect. If the patient is developing respiratory failure after extubation and you want to give a trial, then you have to go for NIV because NIV gives pressure support. NIV gives pressure support and PEEP, which you don't get with this thing. And the patient after the surgery is weak. The diaphragmatic movement is weak and there's overall weakness. NIV is better than high flow in these situations. Okay, so one has to know where high flow is good, where NIV is good. And this is based on evidence. Okay, we are not saying things on our own fancy ideas or whims and fancies. This is based on scientific evidence. In these patients, you have to go with NIV. And like the other things you said are absolutely correct. Now, my last question is I have two questions now. You can answer any of you. Is bilateral pneumonia the same as bilateral ARDS? Any of you can answer.
Usually ARDS will have a diffuse, it may not be a lower zone, it could be a diffuse bilateral presentation, whereas pneumonia will be mostly like a lower lobe. It will have a most commonly in hospital acute, that too with post-operative patients.
Sir, bilateral pneumonia will be like something like bronchopneumonia caused by certain organisms, but it is not similar to ARDS. It is different because ARDS has certain distinct pathophysiology where there is inflammatory cytokine release causing diffuse alveolar damage that might not be seen in bilateral pneumonia, sir.
Very good, excellent. So the answer is that the inflammatory exudate is much more in ARDS. So the hypoxia becomes much more, and the most important thing is the histopathology. The histopathology difference. ARDS is a disease characterized by diffuse alveolar damage, hyaline membranes, hyaline membrane formation. While this is not there in pneumonia. This is not there in pneumonia. So that is why not all pneumonia is ARDS. And not all etiologies in lung disease, bilateral etiologies with hypoxia are considered as ARDS. Okay, this is a histopathology difference. And what can be considered ARDS is still a mystery. Okay, there are many lung conditions which are not considered part of ARDS. So this is the etiological difference, and the etiological difference is based on histopathology, that these conditions which are classified as causes of ARDS have diffuse alveolar damage which has hyaline membranes. This is what is seen on histopathology. Great. Very good, Dr. Ravi Kumar. Now, the final question is, what is the natural cause of ARDS? Supposing this patient stays on the ventilator and you are not doing ECMO, it remains hypoxemic, you are able to maintain ventilation and you are treating the patient. What is the natural outcome of this patient of ARDS? You are not doing ECMO and the patient continues to be in ARDS. There is no shock, there is nothing else.
So over the course of time, the patient will develop fibrotic. When the patient enters fibrotic phase, the patient will have maintaining the PF ratios around 150s, and the patient is having a difficult weaning from the ventilator. But gradually, the fibrosis will improve after maybe months together, like 2 to 3 months. Then the fibrosis will get better, and then they will have a normal vital capacity and normal oxygenation.
Excellent. So that is very good, Dr. Raghupati. These patients, the natural history of ARDS is more than half the patients who go into fibrosis resolve. Okay, and they're able to lead a normal life. So if you are able to maintain the ventilation, right, there should be no barotrauma and no infections and all. A lot of these patients resolve, the fibrosis resolves. Nobody knows why the fibrosis resolves. Okay, so these patients, if they can afford, should not be just shunted away, and they should be maintained. Proper ventilation should be done. The fibrosis resolves over the next month or 2 months, and they're able to lead normal life. Nobody knows what is the mechanism. Okay. Now the final question from my side before I hand it over to Dr. Ray sir. What is meant by phenotypes of ARDS?
So they are subsets of ARDS. They have done on a retrospective data, they have done latent class analysis to find out subset of ARDS, like hyperinflammatory and hypoinflammatory types. These are called phenotypes of ARDS, sir.
So what type was this?
This could be hyperinflammatory.
No, this was hypo.
Sir, so if the patient is has not grown, like if it take secondary ARDS, considering it's a secondary to upper GI surgery, or it could be due to like secondary risk factors are there. So it could be, and the patient had a better outcome within 5 to 6 days, there will be a high possibility of hyperinflammatory ARDS.
No, that is not the correct answer. Dr. Ravi Kumar, is hypo or hyper? What are the characteristics? When you say it's hypo, when you say it's hyper?
Sir, hyperinflammatory will have reduced chest compliance, reduced chest wall compliance, lung compliance will be better.
No, that is not the answer. You should know this. What are the features of hyper and hypoinflammatory? Because it's related to prognosis. So hypoinflammatory and hyper is the one, there is shock. In hyperinflammatory, there is shock. Second is multi-organ failure. And third, there is high fluid requirement. Fourth, there's a high inflammatory markers in hyperinflammatory. And prognosis is worse in hyperinflammatory. So this was hypoinflammatory in all probability. There was no organ failure. There was no shock. We don't know the inflammatory markers and interleukins, and it resolved rapidly. It has resolved very fast. So this is hypoinflammatory. Okay, and this is not secondary ARDS. This is primary ARDS. This is a primary pneumonia in the lung. So this is primary ARDS, and primary and secondary is no more classified as good or bad as far as prognosis is concerned. All right. Okay, very good, Dr. Ravi Kumar and Dr. Pati. So that is all from my side. Dr. Ranjan, you're over to you.
Thank you. Very well done, Rakupati and Rajat. So ARDS is something, though, for the audience, there are a lot of aspects to manage. And most of the time what happens, we although read a lot of things during the practice that is not practiced, but at least few basic things, the few basic principles of ventilation, proning, those should be at least always be followed. That will give you a better result.
So should we close, sir?
Yeah, we should be close. Yes, sir.
Okay. So any questions or comments from the audience?
No, sir. I don't think there is a question.
Okay. So I thank the audience for the patient hearing. Thank you so much. We have a great audience. Thank you, Dr. Raghupati, for making the presentation and being part of the discussion. So it will help everybody, not only you, but all the audience, students, young intensivists. Thank you, Dr. Ravi Kumar, for your participation, and I'm sure all this will go to help you also in future, and all the audience and your colleagues it will help. And I thank especially Dr. Bikash Dey, sir, for organizing this. Thank you so much. Wonderful presentation once again, and congratulations to all of you for making this possible. So thank you, everybody. Thank you so much.
Thank you. Thank you.